Geller. I am making this recording from Vancouver, British Columbia, Canada. And I am not skilled at technology, so I'm very much hoping that this is going to work. My role in Canada, in my program here, is I am the Director of Research at a large tertiary care eating disorders program. So where I work is the center that individuals who are most ill with an eating disorder from all the different communities around British Columbia come to my center. And my role for the past over 20 years has been to direct research activities in that program. And what my heart's desire has been to learn about in this time is what are the nature of relationships that promote change. Very specifically, what's going on in the room, what's going on between me as a clinician and a patient, or between family members and their loved ones, when there is a sense of collaboration, a sense of the individual who struggles with the eating disorder, a feeling that it is an environment that is supportive and helpful and kind of meets them where they're at in terms of their readiness for change and what's going on in the room when that happens. Part of this work has been inspired by my own fascination of times when things have not felt like we're exactly on the same side. Or where there's a sense that either a care provider or perhaps a loved one is, kind of pulling their loved one, trying to make them feel better, or pushing them, nudging them along. And there's a sense that they're not wishing for the same thing that the individual with eating disorder is wishing for. And I think we probably can all relate to that experience. And so I've really dedicated most of my research career to trying to understand how do we get ourselves into a place so that the relationship is as productive as possible, so that the kinds of things that I'm saying and doing are not experienced as unhelpful or possibly even harmful, but that the individual hears it as something that is supportive of them in their recovery journey. So what I would like to do today is share a number of research studies that our group has been involved in, which has been focused on investigating the conditions in which change is most likely to occur. And hopefully there will be some information here that could be of use to you in programs and different parts of the world. I'm thrilled to be participating in this World Eating Disorders Day and love the idea that there are so many of us who will be contributing talks in all different languages. So without further ado, I am going to share my screen with you, and I'm gonna hope that this will work. Okay, I think that it is. I'll just get rid of this. Oops. Oh, okay. Okay, so I love this image, the Carers Balancing Act, because I think those of us, whether we're clinicians or loved ones of someone working with an eating disorder, very often we are juggling many balls in the air and paying attention to a number of different factors in trying to support someone with an eating disorder. So sometimes I think we might feel like an elephant on a tight rope wire, wanting to find the optimal balance of support and encouragement and not being so overbearing and pressuring that it's not helpful. And how do we do that? And because I've always been interested in relationships that promote change, I'm interested in what are the kinds of reactions that we have inside of ourselves that sometimes can interfere with us responding in a way that's most helpful. And so even though we're not together, and even though this workshop is pre-recorded. I was hoping that I could still get our creative juices flowing and to be thinking about or putting ourselves in the position that we're in sometimes when we're in challenging situations with an individual who has an eating disorder. So I have some examples or little scenarios that I'd like you to imagine of when the going gets tough. I think most of us can feel pretty confident that we'll be able to respond in a helpful way when things are going well. But what about when things are more challenging? What then? And so I'd like you to imagine, I've got a few situations here, and just use this as an opportunity to tune in to our own reactions. And part of the reason that I'd like to do this is because toward the end of my talk today, I'll be bringing in the issues of mindfulness and compassion, which I think are kind of everywhere in the world. It's become a very popular topic. There are so many health benefits that have been associated with mindfulness and compassion. And I was hoping that we could bring that in thinking about what is the most helpful way that we can support someone who has an eating disorder. And so this beginning part of my talk will give us an opportunity to identify what some of our own reactions are, and also just to practice an openness to present moment awareness to what's going on inside of ourselves as a means to work with ourselves in a way that is supportive of ourselves, and hopefully that translates into being supportive of the loved ones in our life. So let's take a moment to think about, what if you have a loved one, oops, let me just move this, there we go, who has been struggling with body image and isolating. She's missing meals and is frequently asking you to take her to the gym. So if you had someone in this circumstance, and you can imagine that perhaps she's spending more attention on her body than usual, you notice that she's missing meals and is kind of very focused on exercise, and you've probably noticed that her weight is going down and that there's more of a preoccupation. Can you just maybe take one deep breath and imagine what your reactions to that individual might be? And imagine what's going on inside of yourself. Any thoughts or concerns or places that you go when you see someone who looks like their eating disorder might be becoming stronger. So just hang on to that, and let's try another scenario. So this one's a little bit tricky. What about if a loved one is actually describing a meal plan that sounds quite healthy? So this would be, say, for somebody who is at risk of being underweight. And so she says that she's actually eating 3 meals and 2 snacks per day. But actually what she's saying she's eating doesn't quite coincide with what the number on the scale indicates and what she looks like. And we could just as easily make this example apply to someone who might be going in the opposite direction, who is maybe overweight and trying to lose weight, and describes a meal plan that we would expect the number on the scale to be going in one direction, but actually that's not what is happening. So it's a puzzling situation. There may be lots of reasons for a discrepancy between what the individual describes is going on with their eating and what's actually happening. So it's kind of one of those confusing situations in life where there is some unknown about what's really going on. So just like before, I'd like you to think about what it feels like for you when things don't coincide. It could even be an entirely different situation where just what somebody describes is different from what it looks like when you just kind of use your own observations. What happens for you if we just take a deep breath? If you're ever in that situation where there are things that don't coincide, what does that feel like? I'll just ask you to hold on or think about those feelings in a minute, because we'll talk some more about them in a minute. Here's another situation where the going could get tough. If you have someone in your life who has anorexia, and after making significant gains, and you actually she looks like she's doing well and is not at any health risk, and then after a period of wellness, you notice that this person is losing weight once again and seems to have lost interest in her favorite hobbies and the things that she enjoys and loves to do in life. And this example is someone with anorexia, but it could just as easily be somebody with bulimia or binge eating disorder. What's important about this situation is that it looked like there had been some significant progress, or that the eating disorder was less strong for a while and they were looking well. And then there's been a return of some of the difficulties and looking like it's getting in the way of them also enjoying life and doing things that they like to do. So similar to the other situations, maybe just imagine that kind of scenario for someone that you care about in your life, and think about any reactions that you might have. And finally, this is a scenario that might be more common for a practitioner, a clinician, than for a family member. But I know that there are many families, again, this would be for someone who has anorexia or someone who has a child who has anorexia, that might be using a supplement drink. Here in Canada, we have something called Ensure, which is just like a shake that they can have that has some nutrients and calories. And in this case, the individual with eating disorder says something like, I don't want to eat this lunch and I don't want to have this disgusting drink. They're quite frustrated and angry. And they say something like, why can't I just have what I like? Someone who's clearly unhappy with what they're being asked to do as far as their eating. So again, it doesn't have to be a can of Ensure. It doesn't have to be someone who's wanting to eat more, but just when there's some tension where a loved one is feeling some pressure that they need to be doing something differently from how they're doing it, and is expressing their unhappy feelings about this, and what kind of reactions, if we just take a deep breath and think if you're on the receiving end of that, what are some of the reactions that you might have? So those are just meant to be 4 clinical scenarios to get our creative juices flowing and for us to think about what it's like to be in challenging situations. As I mentioned earlier, what I'm most interested in is the nature of relationships that promote change. What's going on when the spirit or the feeling of the interaction is one that is experienced as helpful and supportive, and that actually is conducive to the loved one moving in a healthy direction. These 4 situations were meant to stimulate us and to think about, what are some of the reactions that could come up inside of us that may lead us to not handle things in the way that we think is likely to be most helpful. So what I have here are just some reactions that you might have experienced. I know I've experienced all of them. We might feel fearful about the health of the person that we care about. We might be fearful for ourselves in terms of what it means about what they're going through. We might feel a sense of hopelessness, that things are not going the way that we had hoped for, and despair about the future. We might feel some disappointment if we feel like maybe our loved one isn't being completely open with us. Or perhaps honest. We might feel sadness for them if we see them struggling or suffering, or for ourselves. Or of course, we could feel anger or some frustration. These are all certainly normal, healthy reactions that I think we can have both as clinicians and as loved ones of someone with an eating disorder who's having some of these challenges. And I guess that's partly why I've become very interested in practicing self-compassion myself in my own life, and also working on a team where we espouse to use a compassionate way of relating to ourselves and to one another. And of course, most importantly, wanting to um, convey this or encourage our patients to have a compassionate approach to themselves in their own recovery. And we have some research that shows that that compassion is associated with better outcomes and certainly many markers of emotional and physical well-being. And I'm going to be ending our talk with bringing this compassion literature into how we address our difficulties with our loved ones. But I'll just give you a little teaser now about what we're meaning when we talk about mindfulness and compassion. There are a few definitions that are out there. One is that self-compassion is being open to the present moment, so that kind of sense of mindfulness and present focused. It's also recognizing that when we struggle, that this is part of the human condition, that it's to be human is to have difficulties and we're not alone in moments of difficulty. And finally, cultivating a spirit of caring and kindness towards ourselves and our inadequacies. So that's one definition of self-compassion that Kristen Neff has come up with. So the idea of mindfulness, a sense of common humanity and kindness. Paul Gilbert is another clinician who has written extensively about compassion, and he speaks of it as a sensitivity to suffering or to struggles with a deep commitment or motivation to try to relieve it. And so, of course, self-compassion would just be a sensitivity to our own suffering with a commitment to try and relieve our own suffering. And so he talks about these three aspects of having the courage to feel what's going on inside of ourselves, a sense of acceptance or wisdom, that it's natural and normal and part of the human condition to suffer, and then having an aspiration or commitment to help. And you can probably hear that there's a lot of overlap between these two definitions, and we'll, as I say, explore more of this at the end of this talk. But I just thought I'd give you a little teaser about it because it has relevance to relationships that promote change. And I think both models, both definitions of compassion can be summarized by having an awareness, being tuned in to whatever's going on. Self-compassion would be inside of ourselves. An acceptance or allowing a recognition that we're not alone in whatever difficulties that we're experiencing. So a sense of common humanity and real just allowing for things to occur, for our reactions to occur. And then having an aspiration to do something about it, to relieve suffering, to reduce our struggles or difficulties. And this could be self-kindness, and it could be applied in lots of different ways that are active ways of making things better. So with that little teaser of self-compassion, and I hope to convey that I see a real parallel in self-compassion and the way we relate to ourselves and collaboration or the way we relate to others. And in talking about relationships that promote change, I'm interested in parallels between how I relate to myself and how I relate to others, and what are the ingredients of those ways of relating that are most supportive and helpful to change. So in this talk, I was hoping to begin by talking about one of my favorite topics, which is a collaborative stance. So the spirit of interactions where things are working, where I'm experienced as helpful. And then take you through a fairly recent study that we did that actually was specifically looking at loved ones who have someone in their life who has an eating disorder, and what we learned about factors that are associated with a spirit of collaboration. And then finishing up with some of our more recent research on self-compassion and how self-compassion may help us to maintain that collaborative stance. So basically it's kind of like self-compassion in action in relationships and within ourselves. So let's start out by talking about definitions of stance. So I'm certainly, our group is certainly not the only one that has been interested in this topic. One of my favorite writers in this area is Janet Treasure, who uh, came up with these different animal analogies to talk about the way that family members could approach someone with an eating disorder or a loved one. And she came up with a few that are all considered to be unhelpful. And you can probably relate to those. You may have seen these already. There is the rhinoceros, who is using a very forceful approach where there could be too much frustration expressed or too much control. So when we come into an interaction with a rhinoceros-like stance, we know from probably from our experience and also from our research that experience is not helpful. And there are other stances that are unhelpful. There's also too much emotion or too much control. So the overprotective kangaroo that doesn't allow their baby, I think they're called joeys, to have exposure to anything that could be in any way upsetting. But this could also be experienced as oppressive and as not allowing enough freedom, and that could be unhelpful. And then there's the ostrich. The ostrich has its head in the sand, and their response is they get overwhelmed so quickly that they, kind of check out entirely. And the ostrich could also be seen as unhelpful because they have no capacity to tolerate emotions. So Janet instead did identify animals also that are considered helpful. And I think there are books written about the dolphin perspective. So this is having this optimal balance. The vision that I often have of the dolphins is two dolphins swimming along together side by side, where there is perhaps occasional nudging in one direction or the other, but that there's just enough caring and control, but there's still freedom for the dolphin to move. I think that's a lovely image. Or the Saint Bernard, who is there in times of difficulty and trouble when you need it with, whatever is in that little first aid kit, but you still have lots of freedom to do things on your own. So those are some of the stances that have been written about in the past. And our lab also, so this is in our research studies, we attempted also to identify what is meant or what is experienced as helpful by our clients who have come to our program in the care that they've received. And our research has looked at clinicians as well as family members and friends. And we've come up with the same basic dichotomy or different two real camps that our stance can be categorized into. On the one hand, more directive, and on the other hand, more collaborative. And I'll tell you a little bit more about this. This is the image that we use to describe directive. And what's important here is that there is one very large person, and this might not be the best graphic, but it's a very large person who is attempting to get a smaller person to do something the way we want them to do it. They might not necessarily be larger physically, but the idea is they take up more space, and there is there's that feeling of I'm trying to make somebody else do something, which is very often, as you would imagine if you were on the receiving end, probably not experienced as helpful. And on the other side, there's a collaborative stance. And here you can see that the two individuals are the same size, and there's more of a reciprocal back and forth spirit between them. And we further were able to delineate what are different ways that we can be directive. We could either be demanding change, which is basically just saying, I expect you to do this now. Or we could offer unsolicited opinions, which is more like an appraisal or an evaluation. So it's kind of letting someone know, I think that what you're doing is not correct, and I don't have a positive opinion about what you're doing. And usually these are unsolicited opinions. And our research has shown that anything in this category is experienced as not helpful and actually gets in the way of change. It actually makes it harder for the individual who hears these kinds of things to make changes. On the other hand, on the collaborative side, Oh, sorry, before we get there, I'll give you some real life examples of directive responses. So a family member saying something demanding might say, you need to stop focusing so much on your appearance. Or an unsolicited opinion might be, you looked just fine before, but now you really need to gain some weight. So those are examples. Care providers can also make directive responses. They might say things like, if you don't fill out these food records, I just can't help you. Or a doctor who says, perhaps frustrated way, this is the 4th week in a row you haven't done this. I just don't think you are engaged. So there's kind of an implied criticism in there. This is the spirit of what it looks like. As I mentioned, there's a big care provider or carer in the case of family members. And the agenda is basically to get the loved one to do something, to do things the way I want you to do them now. And you could maybe just take a second to think about when you're most likely to use a directive stance. Perhaps the examples that I gave at the beginning could have brought out, when we feel more fearful or more frustrated, that we may be more prone to being directive. And we'll discuss that at the end of this talk. But maybe just think about when you're most likely to be directive. But let's go back to collaborative stance. Here, there are also 2 types of being collaborative. One is concerned. So this is an expression of support and caring, independent of change. So we'll talk more about what this stance looked like in real life, but the idea is, the spirit is, I'm not going to let the issue of what I want you to do or not do get in the way of me being able to show and experience caring and support for you. I'm just genuinely concerned, loving, and caring of you. And the last kind of collaborative support, which is probably the one that requires the greatest amount of skill, is what we call encouraging. And this is an invitation to collaboratively work on change together. So it's not just that I'm showing you positive regard, it's that I am inviting you to move in a positive direction, but there won't be any negative consequences to you if you tell me right now that that's not something that you're ready to do. But there is a spirit of collaboration and willingness that is encouraging in the healthy direction, without there being a sense of judgment if it doesn't happen exactly the way I want it to happen. And I'll get into more the nuances of that in a bit. Here are some examples of collaborative responses that a family member could give. So concerned might be, hey, you seem to be having a tough time. Can I do anything to help? Or encouraging could be, this is that really skillful place. How are things going with your eating? And would it help to talk about it? So it's an invitation, but there's still, the participant still has the opportunity to say no, and that would be okay. Care provider encouraging might be, I'm curious, what got in the way of completing your food records? You were saying last week that was something that you really wanted to work on. I'm curious, how are things going? And what has been coming up for you? You'll probably notice that for many of these responses, it's much more important the way we say it than even the words that we use. I think loved ones and clients can really pick up when our words and our body language, in particular, or the spirit, conveys a sense of disapproval or frustration. And so the idea here is to keep ourselves in a spirit where we're likely to be most helpful. And this is the diagram of what a collaborative support looks like or feels like. The carer and patient are the same size, and they are together collaborating and figuring out how can the loved one or patient make the best decisions for themselves, given the plan that they've developed together. So maybe just take a breath to consider, what's going on for ourselves, inside of ourselves, and we're most collaborative. And this will be the topic of the research study that I'll be sharing with you very soon. When are we most likely to use a collaborative stance? What can we do to support ourselves to be collaborative or to use a collaborative stance? And we did try to explore this and pull this apart a little bit more. Like, what do we look like when we're at our best? What does that mean to us as individuals? And we actually came up with 4 basic principles or things that are going on where we're being collaborative, and see how this feels for you. And you think about what you look like or how you come across when you're either being collaborative or directive, or on the receiving end of somebody else who's being collaborative or directive. So the first principle of collaboration is to actually not make any assumptions or judgments. Um, the idea of collaboration, sometimes it's hard to catch ourselves. Sometimes things come out of our mouths without intending to, that there's an assumption in there. So the idea is to really have this wide, open blue sky, offering space to talk about things. And one of the best ways to not make assumptions is to just practice curiosity, to be asking open-ended questions about what's going on for someone, and not having any preconceived ideas about what is happening for them. So it might be, oh, I noticed that you were struggling at mealtime, or how are you feeling, or what has your day been like today, or how are things going for you right now? An aspiration to help with what matters to the patient or to the loved one. So that would be the most important thing, is to be helpful, and not to kind of enforce my agenda on the person. So the spirit behind what I'm doing is an aspiration to be helpful. There are just, even though we're being collaborative, whether we're a loved one or whether we're a clinician, that doesn't mean that there aren't some bottom lines. Certainly as a parent, there are times that there is a framework, there are some expectations. But what's important about when we're being collaborative is that that framework has been clearly explained, that there aren't surprises, that there has been some agreement. This is the way, what we're expecting in a clinical environment or as a family. And that whatever it is that's going on, there are always choices. They might not always be awesome choices, but there are always choices provided. And finally, the spirit of collaboration is that as a family member or a loved one, I'm showing concern and caring that is not contingent upon the patient's behavior or performance. So it doesn't mean that I only love you when you're eating the way I want you to be eating, and that I'm disappointed or frustrated or annoyed when you're not. The concern and caring that I have permeates across any of these different scenarios, which does require some skill and does require that I'm feeling cared for and supported in my own personal life in order to be able to offer this and to hold, these, framework, because sometimes I do need to state an expectation or follow through with an expectation, but I can do this in a way that still shows that I care about what matters to my loved one, and my my support is not contingent on how my loved one is doing or whether they are following a meal plan exactly the way I wish them to. So what I'd like to do now is tell you a little bit about some of our research on collaboration. And some of this comes from support satisfaction. So we have looked at individuals with eating disorders who came to our program and asked them how happy or unhappy they were with the support that they received. And we then asked them to what extent they had received collaborative support that was more concerned or encouraging, or directive support that was more demanding or unsolicited opinions. And what we found, not surprisingly, is that when they described receiving support that was more concerned and encouraging, and where there were fewer unsolicited opinions, that they were more satisfied with the support that they received. And when we looked to see what mattered the most, when we really looked at the the degree of relationship between each of these variables and looked to see what was most contributing. It was that feeling of concern. So feeling like no matter what I do, I have your positive regard, and not being criticized. That when I feel more criticized, I really don't feel supported. So those were the things that were most important in their satisfaction. So concern and refraining from criticism are very important. And again, that wide blue open sky of showing our loved one genuine interest and curiosity, and focus on the individual. So how are you showing caring for them, and it not just being. I think one of the biggest complaints I sometimes hear from patients is that they feel that they're only seen as an eating disorder, that they're not seen as a person. So having an opportunity to connect in ways that have nothing to do with what's going on with their eating. This is one of my favorite studies by a group who showed that when patients on an inpatient unit, in this case, received autonomous support. So when they felt like their parents were helping them to decide how much change they wanted to be involved in with their eating disorder. These are adult patients, so not kids, and there would be some differences with children. But when they felt that their parents were being collaborative with them, that they felt that they were more satisfied with the support that they received. They felt more related to their loved ones. They also felt themselves a greater sense of confidence in themselves and a greater sense of autonomy in themselves. So that like they're driving what's going on in their lives, and that they actually felt empowered to do things themselves. So when they felt that they received support that was more autonomous in this way, they felt more satisfied with the support that they were receiving and better in themselves and more capable in themselves. And this in turn led them to have higher levels of motivation. So you can see changing for myself, not out of guilt or shame, but because taking responsibility for my eating problem is important for me and will lead to things that I want in life. So again, this is for adults with eating disorders, and we now have a very robust literature showing that patient motivation, the more that they're saying that they are interested in making changes, is the best predictor of outcome, or the best predictor of how well they, how much they benefit from treatment, and how well they're doing down the line later on in time. So patients, clinicians, and friends rate collaborative support as more acceptable. It makes them more likely to stay in treatment and more likely to follow a treatment plan. Collaboration is associated with all of these positive outcomes. So I guess that's the summary of the research I've been telling you about before. The more we can be concerned and encouraging, the more satisfied patients are, the more motivated they are, and the better the outcomes. But here's the, I call it the vexing news about stance, or here's the troubling information that we have about stance, which is that despite us having agreement, so if we ask patients what is most helpful to you, they say they want someone to be collaborative. And if we ask clinicians, what do you think is most helpful to patients? They say being collaborative, having this spirit of collaboration. And if we ask parents, parents will also say being collaborative is the spirit that we most wish for. There is unfortunately a discrepancy between what we believe is helpful and what we actually do in practice. So if we look at it, I'll just describe it visually here. If there's a collaboration continuum ranging from very low collaboration to very high collaboration, what we hear is that patients, clinicians, friends, and family all believe that having a more collaborative stance is more helpful to our loved ones or individuals with eating disorders. But in practice, what actually occurs is that we are not so collaborative, that there is this discrepancy between what we believe is helpful and what we actually do. And that has led us to get curious about what gets in the way. When are we off our game? What is it, in perhaps those examples that I gave at the beginning of the presentation today, that's going on when we are less collaborative than we wish to be? When is it hardest for us to be collaborative? And that this is true for family members, friends, as well as clinicians. But this study that I'm going to be telling you about is about families and friends. So I'll just tell you a bit about the study, because I think it has some interesting pointers that will hopefully lead us to sum up in the end some things that could be helpful in maintaining a stance that is most useful and actually feels better for ourselves as well as for our loved ones. So in this study, we had two measures of behavior. We had just first a very simple questionnaire measure where we just asked what types of support are you offering to your loved one. So this particular study was done with friends, parents, relatives, and loved ones of individuals with an eating disorder. So they all completed a measure that asked them, what kind of collaborative versus directive support are you using? And we also, in addition to asking them what they did in a questionnaire, we also gave them some clinical scenarios, similar to the ones that I gave you at the beginning of our talk today, where we showed them like a challenging clinical situation, and we asked them to respond to these clinical scenarios and say, if your loved one was going through this or was doing this, what might you do or say? And we would just ask them to describe what they would say, and we would code those responses afterwards. I'll give you some examples. So the questionnaire, of course, just looked at the two types of collaborative behavior that we have already spoken about. The concerned one, which is expressing caring, warmth, and affection, and encouraging, which is that really difficult but perfect sweet spot of asking what we can do to help. These are just examples of items, but encouraging items in general is moving towards change. It's behaviors that are helping move towards a healthier way of eating, but where there's no judgment or sort of negative consequences to saying no if they're not ready at that moment in time. And also our measures of directive behavior were demanding and unsolicited opinions, though interestingly what we found in this study was that they were interchangeable, that from the perspective of someone who has an eating disorder, if you're telling an individual what to do, and I apologize, I'm often using the pronoun her, but of course it could be male or female, or they, it could be any of these pronouns, but I'll use her because it's more common for us to see females. That we could be telling the person what to do, or we could be criticizing their behavior, that actually they experience it in the same way, that it's all considered to be directive. And these are examples of our clinical vignettes that we used. So this would be one of the written scenarios. Despite being normal weight, Jane always appears to be dieting, making negative comments about her body, and complaining that she lacks willpower around food. Jane blames a recent breakup with her boyfriend on being too fat. And today at lunch, she says she isn't hungry and is going for a walk instead. So you can see it's just a challenging situation, potentially for a loved one. And then we would just ask participants in this study to describe what would you say or do if Jane were someone that you cared about, or a loved one in your life. What might you say or do? And then we would just code these responses. The first part of the results to share with you is that, similar to other projects that we've been involved with, where we've tried to evaluate and look at what kinds of responses are we using, that the majority of the responses were still directive. So again, even though the aspiration of the carers in this research was to be more collaborative, in actual practice, most of their responses were directive in nature, 60%. And that's consistent with other projects that we've done, and I think has continued to inspire us to figure out, what gets in the way and how can we use the stance that is ultimately known to be most helpful. But yeah, so similar to previous work, despite rating collaborative stances most helpful, the majority of responses were directive. And that seems to be part of human nature, that it's really hard for us to maintain a collaborative stance. So we went one step further in this project to try and figure out, well, what are some of the factors that might help us to stay on our game, to use that collaborative stance? Seeing as we know that collaborative stance is associated with these better outcomes, more satisfaction, more motivation. These were the ideas that we had in this study that could be associated with a higher degree of use of collaborative support. And I'll go through each one of them. And if we were all in a room together, and I really wish that that was the case, or that we were even able to do this talk live so we could have some discussion and conversation, what I would ask us to do is set this up as a game show and have you guess if any of these factors, if you think they would be associated with being more collaborative. But because we are not able to do a game show, I will just pretend that you're considering each one. So the first question is demographic factors. Do you think that the gender of the care provider, or the age, or the ethnicity, or whether they perhaps have had a history of difficulties with an eating disorder, or socioeconomic status, how much money they have, or how much education they have, would you guess that any of those factors would be associated with using that encouraging, concerned stance? I'll just take a pause for you to guess. Do you think any of those factors are associated with collaborative support? And if you guessed no, then you would be correct. That actually, in this study, which was quite a large sample of care providers and of family members. In this case, it was mothers, fathers, relatives, and friends of somebody with an eating disorder. And none of these factors were associated with offering collaborative support. So on our list here, demographic factors were not associated. Well, what about beliefs? So do you think that it's the case that if I believe that using a collaborative stance, so in this case, cautious and concerned, that I'm more likely to behave using cautious and concerned or encouraging behaviors? So is there an association that, that if I believe directive is less helpful, that I'll be less directive in practice? So this is meant to see whether my beliefs line up with my behaviors. And so if you want to take a minute to guess, do you think beliefs, what we believe is helpful, is associated with how we behave? The answer was yes, and quite a strong relationship. The good news about that is that this information could be helpful for us. We know collaboration is helpful, and beliefs that being more collaborative are associated with collaborative behaviors. So how can we use this information? Well, we need to do workshops or webinars like we're doing right now. In our program, we have family and friends groups and opportunities for supervision for clinicians and meetings for clinicians, modeling. These are all ways that our beliefs are formed. And when I see other people using a collaborative stance and it working, it makes me want to use it and see that it's helpful. So any of these kinds of opportunities to learn, and by World Eating Disorder Days, having talks like this can also be helpful. Similarly, attendance at family and friends groups where beliefs are discussed is associated with higher levels of collaborative support. So in these factors that are associated with what helps us stay on our game, demographic factors, not so much. But beliefs are, and the more we can have conversations and talk, and probably also talk about what does it actually look like to be collaborative. Again, if we were together, I think we could come up with examples and practice what is a collaborative response, which does not mean that there are no bottom lines or no expectations. It's the way we deliver the expectations that we would want to do in a collaborative way. So the next variable that we looked at was the type of relationship that we have with our loved one. So if you're a mother, a father, a partner, a friend, or a sibling, are any of these groups, do you believe, more likely to offer collaborative support than others? So let me take a minute to think about. And if you guessed that it does not matter, then you would have guessed correct for the data in our study. There were equal levels of collaboration, no matter whether you were a mother, a father, a partner, friend, sibling. They were all, there was no association between any of those roles. So type of relationship was not associated with collaborative support. Well, what about interpersonal style? So we all sort of come into this world with a characteristic way of relating to the world. And these are some of the dimensions that come up on personality scores. We could be more inhibited socially or more domineering. We could have a more cold style or more vindictive style. We could be more accommodating, where we try to make accommodations or allowances or adapt to our circumstances, or more self-sacrificing, or we could be non-assertive or more intrusive. These are all different dimensions that we observe in personality style. And what we found is that actually these personal styles were associated with being more collaborative, where being more collaborative or more patient-centered or loved one-centered was associated. We had more capacity to hear others, more ability to put the needs of others first. We were more collaborative. So again, if we had the resource to be able to look after the needs of others, and also if we just had a style of being less combative and having more warmth. So if we were less prone to picking fights or finding ourselves in more of a combative role, then we were more likely to practice collaboration. How can this help? Well, partly the reason that I gave those difficult, challenging situations at the beginning was to allow us all to just have feelings and to accept that these feelings are natural and normal. We all face time pressures and expectations from ourselves, with our loved ones, our families, and that the more that when we have these difficulties, we can be kind to ourselves, practice self-compassion for ourselves, recognize that that it's normal and natural to have different feelings, and that oftentimes we need to be looked after, could help in setting helpful boundaries with our loved ones. So in terms of interpersonal style, we get a tick mark there. And then the last factor that we looked at to see if it's associated with collaborative support was relationship factors. And so we used a measure here, and it actually, well, we had 3 different ways of looking at relationship factors. And I think these are very relevant for loved ones. The first was, do we have a history of positive experiences? And this is just, have we had the opportunity to spend time with our loved one where we have fun, and it's kind of independent of what's going on with their eating, that we just are having opportunities for closeness and to enjoy time together. That's a positive experience. Like when we think of this individual, can we remember a time that things were positive? Or when we think of this individual, do we come up with thoughts about negative experiences of difficult behaviors, of feeling perhaps stigmatized by their eating disorder, or feeling sense of loss, or some dependency that we experience in a negative way on us, or negative impacts on the family perhaps. And finally, there was a closeness rating, which is just in terms of relationship factors, how close do we feel to the individual, in terms of feeling connected to them. And we looked at the relation between these different types of relationship factors and whether the person was being collaborative. And I thought this might be an illustrative or an interesting way to demonstrate this. So we wanted to see are positive experiences, negative experiences, and feelings of closeness associated with being directed, I guess, to begin with. And the scenario is a bagel. So let's say the objective was for the loved one to eat the bagel. An example of a directive way to try and bring that about would be to say, just eat the bagel. So something very, kind of clear, I'm telling you what to do. And what we found is that people who were more likely to say, just eat the bagel, to be directive, that they were more likely to report negative experiences. So there was no association with positive experiences or closeness, but there was a strong association between negative experiences and speaking in this way. So you can sort of understand that if when I think about the individual, that's what comes up for me, then I'm more likely to be directive. What about cautious concern? So this is one of the collaborative dimensions, and this is the one that is associated with just showing caring and warmth. A cautious concern behavior might just be to check in. How are you doing? What's going on? How's it going with lunch today? Or how are you doing in general? Not surprisingly, that was associated with positive experiences and with feelings of closeness. So if I can remember doing things that I enjoyed with my loved one, and if I remember feeling close, I'm more likely to respond in a cautious, concerned way. And then finally, this is the one that I think I may have mentioned before, the sweet spot. I think we are at our best as clinicians and as loved ones when we're being encouraging. So it's not just that I'm showing you positive regard, but I'm also talking about, the healthy behavior, the thing that we're hoping to have more happen or happen more. So something like, how can I support you to eat this bagel? Interestingly, that was associated with all three types of experiences. So having positive experiences, having negative experiences, and feeling close. And I think this is really important and relates to our challenging experiences and how to support ourselves in a very important way. It means that, yes, we need to encourage activities that foster closeness, where the eating disorder is not a focus. So we know that to be the case for sure. But also not to be afraid of our reactions, that in offering encouraging support, both positive and negative experiences can galvanize healthy boundaries and limit setting. So I want the positive experiences in order to offer the support and warmth, but the negative experiences also help me to figure out a frame or some boundaries so that I can have conversations about what I'm wishing for you, but in a way that I'm not blaming you or being critical, that there's still a conversation and choices. So how can I help you with this? We talked about earlier that you've committed to eating 3 meals and 2 snacks per day, and you would like my help in these ways. Here I am offering help in these ways. What will this look like today? So important to not be afraid of our reactions. In a clinical environment, it might be a patient having a choice between eating a meal that's provided or replacing with a meal supplement. And then my job as care provider is, how can I help you make the best decision for you? So it's always trying to get out of that role of, you must do this, but we had this plan that we agreed on that you would do this or this. How can I help you make the best one for you? So it's a lot of the planning that happens beforehand that's more important. And in our little diagram here, of course, relationship factors gets a tick. So from this study that I was telling you about, we've learned that collaborative support is associated with all these better outcomes. And we learned that things that contribute to collaborative support are beliefs that collaborative is helpful, having a style that's more warm and less cold or vindictive, really allowing ourselves to have our own reactions, but then supporting ourselves enough that we can offer a stance that's most helpful to our loved ones. And these relationship factors, again, it's possible for us to have both positive and negative experiences, and that all positive, negative, and closeness actually contributes to being encouraging. So in summary, the things that help us to be more collaborative are beliefs, practicing self-care, using positive and negative experiences in a helpful way. And I was hoping just to wrap up by bringing this back to our relationship with ourselves and what I was touching upon earlier in terms of mindfulness and compassion, which I know most people have had some exposure to. The two definitions of mindfulness and compassion that I mentioned earlier connect very much with this, very simple model of awareness, acceptance, action. Awareness of what goes on inside of myself when I'm in a situation with a loved one that might be challenging or difficult for both of us. And the acceptance is this really important part. In fact, some people think of acceptance as like internal action. It's rather than try to rush to doing something about it. I notice this is a difficult scenario. Maybe I'm upset with you because I'm not clear about what you're telling me, if that coincides with what is actually happening, or you were doing so well and now you seem to be relapsing. I'm aware of my reactions. Before I actually say or do anything, acceptance is just kind of acknowledging that, change is really difficult. That sometimes people make that there are slips, that the recovery path is one that has ups and downs, and that ideally we would learn from different slips, but it's certainly part of the human condition to have these ongoing opportunities for growth and learning. So taking the time to accept that this isn't, something I need to judge, that it's part of the human condition for these challenging situations to come up, which then leads to hopefully the most self-kind action to be offering to our patient. And I'll just summarize with a couple of points that I learned from my good friend Paul Gilbert, who is, of course, one of the granddaddies of compassion work. We started out this webinar by talking about some of the reactions that we might have, such as feeling fearful or angry or sadness. And the idea, if we think about mindfulness and self-compassion, which to me is very much the spirit of the ingredients that we were talking about in collaborative care, being curious and open, that the type of ingredients that happen between two individuals in interaction, is using that spirit of allowing myself to have these different reactions and relating to them in a kind way. So what would it look like to relate to these reactions in myself in a kind way, in an accepting way, or an internal way? And so in compassion models, if I feel fearful, I learned this from Paul Gilbert, perhaps the action that I need to have inside of myself first is to support myself. I got this. I might be afraid for my loved one, but I can still behave in a way that is going to be most helpful. That I don't need to be completely overwhelmed by my thoughts about what might happen in the future. I can actually relate to this situation. I can just allow myself my feelings and figure out a way to respond in a way that is going to be helpful. If I'm feeling angry, the internal action might be, validation. I think it's when we feel like it's not okay to be angry that we're really in trouble. That instead we could say, my reaction makes sense. It's understandable to feel this way. Everybody gets angry sometimes, and just give myself permission for my feelings before moving into action. So you can see how this acceptance step is so important, and why those deep breaths can be so important. And finally, sadness. The internal action that I would wish for is comfort and soothing. The sadness is when I want, perhaps a warm blanket or a hug or a cup of tea, and I want to, let myself know that my feelings matter too, and I can be nurturing and caring toward myself. And what our research is showing now, and what I think the next sort of steps that we're going towards, is that if we can support our loved ones to practice compassion and practice acceptance of these difficult emotional experiences that we all have. So if we apply a state of compassionate skills to these kinds of situations, that our aspiration, what we seem to be seeing, is that it's more possible for us to behave collaboratively, which is ultimately what our patients and what we most wish for ourselves. Well, that was a lot of information, and I think it took about an hour, which is, I think, about the amount of time that I was expecting. I really hope that this was helpful and that there was something in here that could have been of use or help. If you have any questions about any of this or would like to get copies of any of our research studies, I would be more than happy to send them to you. My name is Josie Geller, and feel free to email me. I just noticed I didn't put it on this slide, but I'm sure it will be available to people who participate in this day. So thank you for your attention, and happy World Eating Disorders Day. Oh, and I guess I should stop the share and yes, just say thank you very much. And I look forward to hearing other people's talks on this day. Okay, bye for now.